Hello everybody. Today we are going to discuss about the acute liver failure. So acute liver failure is the clinical syndrome characterized by encephalopathy, jaundice and prolonged prothrombin time, that is INR more than 1.5, developing in patient without pre-existing liver disease within 4 weeks of onset of symptom. A few patients presenting with the acute liver injury, mostly due to drug-induced liver injury, may develop encephalopathy later than 4 weeks up to 8 weeks. Now we'll see what are the causes. So causes is the infectious etiology, mainly caused because of the virus. That is acute hepatitis due to hepatitis A virus, hepatitis B virus, HCV, HDV, and HEV. Acute infection due to non-hepatotrophic viruses, that is herpes simplex virus, varicella zoster virus, cytomegalovirus, Epstein-Barr virus, herpes virus type C, parvovirus B19, adenovirus, hemorrhagic fever virus, Coxsackie B virus. Then drugs like paracetamol, antibiotics like isoniazid, pyrazinamide, tetracycline, amoxicillin, clownic acid, halothane, sevoflurane, and other derivative, antidepressants like MAO inhibitors, imidazopyridine derivative, non-steroidal anti-inflammatory drug, and anti-thyroid drug. Others are hydantoins, alpha-methyl dopa, ketoconazole, amphetamine, and sulfonamide. Toxins include mushrooms of Amanita group, that is A. phalloids, A. verna, and Lepiota. Industrial solvents like carbon tetrachloride, trichloroethylene, white phosphorus. Illegal drugs like cocaine, ecstasy, and others. Traditional Chinese medicine, chaparral, and other natural products. Vascular diseases like ischemic hepatitis, like shock liver, and hepatic failure, ligation of the hepatic artery, especially if the portal thrombosis coexist, acute Budd-Chiari syndrome. Others like chronic autoimmune hepatitis as presentation of the disease, Wilson's disease, pregnancy, acute fatty liver, HELLP syndrome, hypothermia, heat stroke, massive tumor infiltration, Reich syndrome, urea cycle disorder, and partial hepatectomy. Then undetermined cause includes HELLP syndrome, hemolysis, elevated liver enzyme, and low platelet count. Now about pathogenesis, ALF is preceded by acute liver injury which manifests with the varying degree of hepatocyte cell death. The mechanism involved in the liver injury differs by the etiology. Acute hepatitis B infection is associated with massive lysis of infected hepatocyte by the immune system. Paracetamol overdose with the toxic metabolite. Amanita phalloids intoxication with RNA synthesis blockage. Shock with the ischemic necrosis, and acute fatty liver pregnancy with mitochondrial dysfunction, and among others. On the other hand, host response to the massive liver necrosis occurs with the release of damage associated molecular pattern from the dying hepatocytes and endothelial cell underpins a significant immune reaction that may further causes severe systemic inflammatory response with the release of both pro-inflammatory cytokines such as interleukin 6, TNF alpha, hepatic growth factor, and anti-inflammatory cytokines. Liver failure and the deranged systemic inflammatory response may lead to the development of vasodilatory shock, acute kidney injury, metabolic abnormality, and vulnerability to the infection. Moreover, the failing liver is unable to convert ammonia into urea, causing accumulation of this neurotoxin, which may lead to astrocyte swelling and intracranial hypertension. Sepsis with multi-organ failure and intracranial hypertension complicated by cerebral herniation as a main cause of death in the patient with acute liver failure. In recent cohort of patients with acute liver failure who were on the waitlist for elective liver transplantation, 28% of death were due to complication from cerebral edema and the rest due to multi-organ failure. Now about lab workup, disease severity and complication. Full coagulation screen include prothrombin time, INR, fibrinogen, and the factor 5. Liver test includes LDH, conjugated, unconjugated bilirubin, and creatinine kinase. Renal function test include serum creatinine, urea, and urine output, arterial blood gases, and serum lactate. arterial ammonia, serum amylase, lipase, blood, and the urine culture. Then etiology specific diagnosis include in the urine, paracetamol serum level in paracetamol overdose, amanitin in urine in mushroom poisoning, microbiological screen for the virus infection like HBsAg, anti-HBc IgM, HBV DNA, Delta virus if HBV, anti-hepatitis A virus IgM, anti-hepatitis E virus IgM, and hepatitis E RNA, hepatitis C virus and HCV RNA, cytomegalovirus, herpes simplex, herpes zoster, Epstein-Barr virus, parvovirus, PCR. And then markers of autoimmunity like serum level of immunoglobulin, ANA, smooth muscle antibody, anti-soluble liver antigen. Now, after evaluating everything, we need to take the urgent decision of referral to the transplant center if there is a proper indication for the liver transplant. So, suggested criteria for the referral of patient with acute liver failure to specialist unit is if it is happens because of the paracetamol or hyperacute etiology, then the criteria are arterial pH less than 7.3 or bicarb less than 18, INR more than 3 on day 2 or more than 4 thereafter, oliguria or elevated creatinine, altered level of consciousness, hypoglycemia, elevated lactate unresponsive to fluid resuscitation. Then if it is because of the non-paracetamol poisoning, pH less than 7.3, bicarb less than 18, INR more than 1.8, oliguria, renal failure or sodium less than 130, encephalopathy, hypoglycemia or metabolic acidosis, bilirubin more than 7.6 and shrinking liver size. Now about general management. Critical care management of the patient with the ALF could resemble that of any other patient in ICU, but has specific aspects that deserve consideration. If ALF is suspected, all drug that patient was previously receiving should be suspended. Additionally, maneuver that further worsen or could resemble hepatic encephalopathy should be avoided. There is no evidence that treatment with disaccharides or rifaximin are effective in the treatment of hepatic encephalopathy in ALS. Lactulose enemas are contraindicated due to risk of increasing intracranial pressure. The administration of intravenous N-acetylcysteine improves transplant-free survival in case of non-paracetamol ALF with early stage of hepatic encephalopathy. This treatment is ineffective if hepatic encephalopathy worsened to the grade 3 or 4. Close control of consciousness level is essential in the management of patient with the ALS. It should be checked very frequently, usually every 6 and every 2 hours, 12 hours, or even 2 hours. Patient with the grade 3 or 4 hepatic encephalopathy requires intubation for airway protection and prevention and management of intracranial hypertension. Once intubated, sedation and analgesia must be initiated. The recommended general management of patient with the ALS is there. There. We'll discuss that. So about etiological management, early initiation of treatment targeting the cause of ALF when available is of paramount clinical relevance. So administration of N-acetylcysteine in paracetamol overdose. So that is 150 mg per kg in 1 hour, 50 mg per kg over 4 hours, 100 mg per kg in next 16 hours, and 50 mg per kg in 24 hours for 3 to 4 days. Glucocorticoid in autoimmune hepatitis without severe hepatic encephalopathy, that is 1 mg per kg. Penicillin G in Amanita phalloid poisoning, intravenous acyclovir in herpes 1, 2 or zoster infection, that is 10 mg per kg every 8th hour. Tenofovir or entecavir in hepatitis B ALF. Expedited delivery in acute fatty liver of pregnancy or health are measures that should be initiated immediately after the diagnosis has been established. Ribavirin may also be considered in the ALF caused by hepatitis E virus since it may reduce the morbidity, but there is no evidence of its efficacy. Therapeutic plasma exchange is indicated to treat acute hemolysis in Wilson's disease. Once major liver damage is established, that is grade 3 or 4, etiological measures are much less effective and potentially harmful. Now, about cerebral edema and intracranial hypertension. Intracranial hypertension is a complication mainly observed in hyperacute form of ALS, having declined in the incidence in the recent years. Two main pathogenic factors are high ammonia level leading to astrocyte swelling and systemic inflammation. Patient with more than one of the following, that is young patient with acute or hyperacute form, persistent increase in ammonia of more than 150 to 200 liter mol per liter, AKI and norepinephrine more than 0.1 mg per kg per minute are at highest risk of intracranial hypertension. Clinical monitoring of this complication is essential. Insertion of intracranial pressure sensors, mainly in extradural space, was frequently used in past for this purpose. This sensor allows the continuous evaluation of ICP and estimation of cerebral perfusion pressure, and ICP should be maintained 15 mmHg. The invasive technique has been replaced by non-invasive method, mainly transcranial Doppler ultrasound of cerebral arteries, that is cerebral flow and pulsatility index, and by evaluation of optic nerve sheath diameter. If it is more than 0.48 centimeter, then it is suggestive of intracranial hypertension. The disadvantage of non-invasive method is that information given is discontinuous. Several measures are applied to prevent cerebral edema and intracranial hypertension in ALF, including facilitating venous drainage, that is head elevation 30 or more, avoidance of nociceptive stimuli, control of agitation, avoidance of hyponatremia, prevention of hypo or hyperglycemia, avoidance of fever and hyperhydration, osmotic therapy with mannitol of 0.5 to 1 gram per kg, and hypertonic saline of 10% to 30% is the first line treatment for intracranial hypertension. CRRT can be used if there is no response to osmotic therapy in presence of serum ammonia more than 150 to 200. Muscle relaxant and the moderate hypertension are other measures that can help to control intracranial hypertension. Second level intervention indicated in refractory cases are moderate hypothermia and barbiturate coma. In desperate cases of uncontrolled intracranial hypertension, refractory shock, toxic liver due to massive necrosis, emergency hepatectomy is indicated in some center with aim of achieving clinical improvement while awaiting organ. Now about cardiovascular support. Cardiovascular alteration in ALS are characterized by the hyperdynamic circulation, that is high output, and peripheral vasodilatation that could compromise end organ perfusion, causing lactic acidosis and AKI. So hypotensive patient should be carefully resuscitated, preferably with the normal saline to avoid congestion and ensure organ perfusion. Fluid overload is especially deleterious in ALS since it causes the risk of intracranial hypertension due to worsening cerebral edema. In a study involving patients with ALF, fluid responsiveness was observed in only 29%. Preload dependency parameter based on pulse counter analysis effectively predicted fluid responsiveness. In persistently hypotensive patients, vasopressors should be initiated, norepinephrine being the preferred drug. Vasopressin should be added to norepinephrine in case of refractory hypotension. Stress dose hydrocortisone, that is 50 mg every 6 hours, should be considered in vasopressor resistant hypotension, given the high prevalence of relative adrenal insufficiency in the air. Several studies shows that molecular absorbed reticulating system and high volume plasma exchange improve hemodynamic stability in patients with ALF requiring vasopressor support. Now about respiratory failure. The incidence of respiratory failure is low in ALS. However, a liver transplant is contraindicated in patients developing refractory respiratory failure. Ventilatory setting should be protective using low tidal volume and appropriate, usually low to moderate positive end expiratory pressure. Hypercarbia and hypocarbia should be avoided with CO2 target between 34 to 41 mmHg. Extracorporeal membrane oxygenation could be considered as a bridge to liver transplant in highly selected patients with reversible respiratory failure and as a rescue therapy for refractory respiratory failure in post-transplant patients. Now about acute kidney injury and renal transplant therapy. AKI is highly prevalent in ALF and is associated with poor outcome. Up to 70% of patients in the US cohort had AKI with 30% requiring renal replacement therapy. CRRT is the preferred modality because it is associated with low risk of cardiovascular instability and cerebral edema. CRRT effectively decreases ammonia level, and in the last decade, hyperammonia has become increasingly common indication for RRT in ALF independently of presence of AKI. Several studies suggest that early CRRT improves survival in this setting by preventing severe hyperammonemia and its associated complications. Now about nutritional support and metabolic control. The role of nutritional support in ALS is to provide sufficient energy, vitamin, trace element, and facilitate adequate protein synthesis and avoid metabolic complications such as hypoglycemia and hyperammonemia. In patients with the ALS with high arterial ammonia level who are at risk of cerebral edema, nutritional protein support can be deferred for 24 to 48 hours until hyperammonemia is controlled. When protein administration is started, arterial ammonia should be closely monitored to ensure no pathological elevation occurs. Hypoglycemia is the frequent manifestation in patients with ALS due to decreased hepatic glycogen store and impaired gluconeogenesis and glycogenolysis. Hypoglycemia can contribute to hepatic encephalopathy and has been associated with increased mortality. Therefore, periodic monitoring of the glycemia is recommended every 6 months. Now, management of coagulopathy. Global assessment of the homeostasis in ALF indicates rebalanced state. Compensatory mechanism has been identified for each phase of homeostasis. Pro-homeostasis driver may overcompensate for deficient liver-derived coagulation factor and result in relative hypercoagulable state. Therefore, prophylactic transfusion of FFP or other blood product is unwarranted and may expose patient to harmful effects such as volume overload, brain edema, transfusion reaction without any clinical benefit. A recent study by Stravitz et al. Identified an association between coagulopathy assessed by rotational thromboelastometry, bleeding event, and mortality in patients with ALS, highlighting the clinical utility of rotational thromboelastometry in this setting. Now about prevention and treatment of infection. In patients with ALS, sepsis can manifest at any time in the course of the disease. Early infections are mainly attributed to immune dysfunction, while late episodes are also facilitated by the high degree of instrumentation required in the management of this patient. So, bacteria implicated in early infection arise from the patient's normal flora, while later infection involve exogenous bacteria and fungi. Most endogenous infection occurs within the first. The susceptibility to the bacteria and fungal infection, sepsis, and septic shock is notably increased in patients with ALS, with infectious complication being the leading cause of death in this setting. So, bacterial infection have been documented in 60 to 80% of patients, most commonly presenting as pneumonia in approximately 50%, urinary tract infection 22%, catheter-related bacteremia 12%, spontaneous bacteremia 16%. Infections by multi-drug resistant organisms are also associated with higher incidence of grade 3-4 hepatic encephalopathy, multi-organ failure, longer hospital stay, and trend towards higher mortality. Fungal infection, largely caused by Candida, occurs in about one third of patients requiring prolonged critical care support. Diagnosis of infection in patient with ALF is difficult and the clinical features are non-specific and tests such as C-reactive protein and PCT measurement are frequently unhelpful. High level of clinical suspicion should be maintained. Empiric broad spectrum antibiotics should be administered to patients with ALS who have signs of sepsis, persistent hypotension, and unexplained progression to the high grade of hepatic encephalopathy. Antifungal therapy should be considered in patients with prolonged organ support. Use of biomarker to guide treatment of invasive fungal infection is recommended. So empirical antibiotic is recommended for patients listed for super urgent liver transplantation since the development of infection and sepsis may prompt delist. Now about liver support system. Hepatic failure in the ALF is reversible in many cases given huge regenerative capacity of the liver. This explains why liver support system could have great potential in ALF as a bridge to liver regeneration or elective liver transplantation. This system should support all liver function, including synthesis, excretion, and metabolism. Unfortunately, such a system does not exist. The greatest clinical experience with artificial liver system, albumin dialysis system, are based on the scavenger capacity of the albumin, that is capable of removing water soluble and albumin bound toxic substance which accumulate and promote systemic and hepatic inflammation. This is also called as MARS, that is molecular absorbent reticular system, and Prometheus. Unfortunately, these systems have not been shown to improve survival in the ALF and are not recommended in current guidelines. Bioartificial liver support system contains hepatocyte in bioreactor. Published studies performed in the past also failed to show consistent reduction in the mortality. Currently, bioartificial liver support systems are not available in the market. Therapeutic plasma exchange is the most effective liver support treatment currently available and the only one indicated according to current guidelines. It is used as bridge to liver transplant or to spontaneous recovery in cases with the good prognosis, like paracetamol and hepatitis A virus, when liver transplant is contraindicated. It has detoxifying and immunomodulatory effect. High volume plasma exchange, that is 3 plasma volume, improves transplant-free survival. Recent studies suggest that effectiveness of therapeutic plasma exchange using low doses, that is 1.5 to 2 volume plasma with fewer adverse events. In recent study, therapeutic plasma exchange has become routine therapy in patients with ALF in several centers, given its effectiveness, safety, ease of use, and low cost compared to other therapies such as albumin dialysis. It is important to remark that replacement solution is FFP. Therefore, INR cannot be used as prognostic marker after initiation of therapeutic plasma exchange. Now, the criteria for the liver transplantation. The original King College criteria is non-transplant etiology. Consider transplantation if encephalopathy INR more than 6.7 or any of that is unfavorable etiology, acute or subacute presentation, bilirubin more than 300 micromole per liter or INR more than 3.5. If there is paracetamol etiology, then consider transplantation if arterial pH is less than 7.3. After adequate intravenous volume resuscitation or concurrent finding, hepatic encephalopathy is more than or equal to 3, creatinine more than 3 or INR more than 6.5. So this is this algorithm which showed the management of the acute liver failure. If there is acute liver failure, if INR is more than 1.5 and the patient is in hepatic encephalopathy, then ICU admission is indicated. After admission to the ICU, we need to proceed with the diagnostic workup. So diagnostic workup should be directed should be divided into two parts for etiology, identification of the etiology, standard analysis, and test. For identification of the etiology, we need to send toxicological screening like paracetamol, cocaine, and amanitis, HIV, HBV, HCV, HEV. Then CMV, herpes virus 126, the ABV virus, parvovirus in immunocompromised patient. Then markers of autoimmunity like anti-ANA and smooth muscle antibody, copper metabolism. Consider transjugular liver biopsy. Etiology remains unclear. Then standard analysis and test include CBC, including liver, kidney coagulation test and ammonia level, blood culture, urine culture, rectal swab, nasal swab, chest X-ray, abdominal color ultrasound, and CT imaging of chest, abdomen, and pelvis. Then initiate medical treatment like N-acetylcysteine, paracetamol overdose, and non-paracetamol ALF with non-severe hepatic encephalopathy. Intravenous electrolyte support to address metabolic disarray like hyponatremia, hypoglycemia. Initiate etiological treatment if possible. Correct coagulation abnormality only if bleeding and before a high-risk invasive procedure. Low threshold for prophylactic systemic antibiotic. Consider selective intestinal decontamination. Proceed with the orotracheal intubation if evolving an established grade 3-4 hepatic encephalopathy. Deep sedation and analgesia, head elevation to 30 degree, norepinephrine if arterial hypotension, and protective mechanical ventilation. If there is intracranial hypertension, uh, then consider mannitol hypertonic saline, CRRT to maintain ammonia less than 100. Then assess the patient for the liver transplantation. If there is a urgent need for liver transplantation, then go for the urgent liver transplantation. Consider plasma exchange with FFP if clinical deterioration. If there is a contraindication to liver transplantation, take help of bridging therapy like plasmapheresis. Thank you, guys.